Good afternoon, everyone. My name is Aisha Usman. I work at Mental Health Foundation Australia, and I am your host for today's webinar. We begin by acknowledging the Wurundjeri people as the traditional custodian of the land on which our office stands, and pay our respects to their elders, past and present. We extend that respect to any Aboriginal or Torres Strait Islander peoples tuning in today. On behalf of the Mental Health Foundation Australia, I would like to welcome and thank each one of you for attending today's Lunch and Learn educational webinar on transdiagnostic factors, their overlap in mental health symptoms and insomnia. I would like to introduce our presenter, Adjunct Professor Amanda Richdale. Amanda is a researcher at the Olga Tenson Autism Research Center at La Trobe University. She is also an educational and developmental psychologist. She has worked in the autism field for over 30 years, including early intervention and assessments and diagnosis, where her primary research interest is autism and co-occurring conditions, particularly sleep difficulties and their interrelationship with mental health. Amanda led the Autism CRC's longitudinal study of Australian school leavers with autism, which examined social, emotional, and mental health and physical health factors in autistic young people aged 15 to 25 years, over 2 years. Currently, her research interests focus on factors underlying sleep and mental health difficulties in autistic and non-autistic populations, and working with colleagues to investigate acceptance and commitment therapy as an intervention approach. Please join me in welcoming Adjunct Professor Amanda Richdale.
Thank you very much, Aisha. And I'm very sorry for this recording happening an hour later. I made a misentry in my diary and didn't discover it until late this morning. So today I'm going to talk a bit about transdiagnostic processes in mental health, but I'm going to have a particular focus on insomnia as a transdiagnostic process. So I'm going to start by talking a little bit about transdiagnostic factors and mental health, look at overlap in mental health symptoms across disorders, have a bit of a brief look at poor sleep or insomnia and how it might act as a transdiagnostic factor for anxiety and depression. So I'm going to concentrate on anxiety and depression, what the evidence is, and where we might go to next with these sorts of ideas. So first of all, as clinicians or researchers today, we've probably all heard about transdiagnostic factors as targets for intervention or explanation for the high rate of co-occurring conditions in mental health diagnosis in a single individual. It's quite common for individuals to have 2 or more mental health diagnoses. So here's a definition from a recent paper by Rovs and colleagues. Transdiagnostic factors are shared processes that may cause or maintain multiple health disorders or comorbid mental health disorders and may thus explain why mental health disorders often co-occur. So if we look at this top box here, based on the DSM or the ICD, we tend to think of mental health problems as fitting into nice, clear little compartments or boxes. We have a set of diagnostic criteria and we decide if someone's depressed or they has a mood disorder, or they're anxious and have an anxiety disorder and so on. Or we might decide that they've got a sleep disorder or insomnia. I should have written that as a sleep disorder rather than an insomnia disorder. So we make these kinds of decisions, and then often we give people, more than one. So what we often find is that someone who comes to us has depression, symptoms of depression, they have symptoms of anxiety, and they have some insomnia symptoms. Or they might have, we might think they have bipolar disorder, but they're also exhibiting irregular sleep-wake patterns, for example. So what a transdiagnostic approaches have is the potential to better represent the clinical and scientific reality of mental health problems, to reflect the complexity and the dimensionality and comorbidity that's the norm that people see in clinical practice. So why is it that things like depression, anxiety and insomnia might go together? Why is it that irregular sleep-wake patterns perhaps might go with something like bipolar disorder? One set of criteria which have been around since about, I think they were first launched in 2009, is the National Institutes of Mental Health in the USA's research domain criteria, more commonly known as RDoC. And this was an early, and still is, a research framework for investigating mental disorders. It's a transdiagnostic approach that tries to consider mental health in the context of major domains of basic human neurobehavioural functioning and within current diagnostic categories. It's transdiagnostic because it attempts to account for the heterogeneity and symptom overlap that we all see in mental health. It's also a lifespan approach because it tries to understand both typical and atypical brain development and how this can inform development of mental ill health at biological and behavioural levels, and also environmental factors. And so it tries to be a biopsychosocial approach. It doesn't seem to have a particularly strong theoretical background per se, and some people have criticised it recently for that. Nevertheless, it's a well-known approach to try and look at this question of transdiagnostic criteria. So you can, I'll go back to that other slide. If you go to the website that I've got up there, or you just put in RDoC, there's a huge amount of information on this particular approach to a transdiagnostic approach to mental health. So the RDoC has a 6-factor research matrix. So the factors are negative and positive valence systems. So negative valence system involves threat, anxiety, fear, loss. Positive valence system involves things like positive motivation, habits, reinforcements. It also looks at cognitive systems, social processes, arousal and regulatory systems, which involves the sleep-wake rhythm, which is what we're going to talk about today, and sensory motor systems, which it considers to be related to compulsive and stereotypic behaviours. And within these systems, variously, one might look at genes, and they're at the moment reevaluating their criteria for how this may be done. Molecules, so neurotransmitters, neurohormones, for example, different brain circuits in the brain. So one might be circuits related to the amygdala. Physiology, so heart rate, skin conductance, behaviour, perception of self, laughing, crying, self-report measures to do with things like, so for example, sleep quality, emotional awareness, and what they term paradigms. So where we actually measure things like sleep, we look at people's responses to a range of psychological tasks. Not all of these factors for analysis will be listed under all of these research systems and factors in the research matrix. But that's sort of an overview of what RDoC tries to do. So, for example, if it was RDoC was looking under the cognitive system, it would be looking at things like attention, memory, perception, and language. If they were looking at social processes, they might look at people's responses in interpersonal settings and people's perceptions of interpersonal factors. And so thinking about this biopsychosocial approach, this was not based on RDoC, but I thought I'd put up a model of ours looking at a biopsychosocial approach of sleep in autism, which we developed a number of years ago, and this is a sort of slightly updated version, which kind of I hope gives the transdiagnostic flavour for you. So if you think about sleep in autism, we've got the things that might seem to be related to autistic traits, sensory sensitivities and routines. Though these sensory sensitivities and routines are also important for sleep in non-autistic people. We have biological factors So we might have genetic factors related to autism, related to clock genes, for example. We might have melatonin, which you've undoubtedly all heard of, and we have circadian rhythms. Over here, we have the environmental factors, so people's unique environments and shared environments, and the families that we function within. These environmental factors may lead to stress. These biological factors may lead to somatic arousal. And down here, we have a range of psychological factors that we know are related to sleep. So disordered sleep sitting here in the centre, and there are all these possible causes for the disordered sleep that we see. And the question might be, well, where do we target our intervention? We have to look very carefully at our client, and we have to think about the multiple places where which might be causing the disordered sleep. From a research perspective, we also need to think about, well, where will we target our research? What might be what, for example, might relate to insomnia? Is it arousal? Is it stress? Is it anxiety and cognitive arousal down here associated with anxiety disorders? So they're thinking about things within a transdiagnostic perspective, and all of the things that might lead into a particular problem that we're seeing in a client or in a patient leads us to think about ways to conduct our research and to decide on points of intervention. So now to look more specifically then at anxiety and depression and how they might relate to insomnia. And I'm going to start off with a model before I do this, which not only includes anxiety and depression and insomnia, but also includes other transdiagnostic factors. Because insomnia is not the only, as you've probably now realised, insomnia is not the only transdiagnostic factor that's around. So this was with autistic adults aged 15 to 80 years, and we're hoping to submit this paper within the next couple of weeks. And there were just over 200 autistic adults in this study. And intolerance of uncertainty is considered in the literature to be a transdiagnostic factor for anxiety in particular. And sensory sensitivities and autonomic arousal are also often considered to be transdiagnostic factors. So we looked at, given that these were autistic people, we also looked at the degree of autistic traits, because we know that autistic traits are associated particularly with mental health problems. High autistic traits are associated with mental health problems. And this was a path analysis. And if we look at this path analysis, we can see that autistic traits, increased autistic traits, are related to anxiety only. Our little box here of transdiagnostic factors, intolerance of uncertainty, sensory sensitivity and autonomic arousal, the intolerance of uncertainty related to anxiety and depression. So this is another important transdiagnostic factor that we could potentially intervene for, that I'm not going to talk about today, that also seems to contribute to both anxiety and depression. Then if we look at sensory sensitivity, it relates to depression, which surprises a little bit, and also to insomnia. And autonomic arousal relates to insomnia. So where does insomnia fit into this picture? There's a level behind insomnia in sensory sensitivities and autonomic arousal in this sample that leads to insomnia. And then insomnia then impinges on anxiety and depression. So we've got this little triangle here. It's not drawn as a triangle, but if we can think of it as a triangle of anxiety, depression, and insomnia. And then we've got another group of transdiagnostic factors behind them that also affect them. And this model was pretty good at describing what was going on. It described 37%, counted for 37% of variance in anxiety, 48% of variance in depression. And here it accounted for 29% of, the model accounted for 29% of variance in insomnia. So to concentrate more on the insomnia aspects, how common is poor sleep? How often might we expect to see insomnia or poor sleep in our samples? In the general population, up to 40% of young children may have sleep problems. And this goes down a little bit in middle childhood to around 20% of children, increases again significantly in adolescence. And Australian adults, 18 plus, are reporting inadequate sleep in up to 45% of adults. In autism, which is, as you know, is my particular interest, we find very high rates of sleep difficulties in children, in young children and in middle childhood. Similar rates of sleep problems reported by adolescents as to what we see in non-autistic adolescents, and very high rates of poor sleep quality in adults. I think this is important to remember, as well as what we're seeing in the general population, because these days autistic people are coming very much more into our practices, particularly autistic adults. So if we think about the DSM-5 and mental health disorders, this is a table drawn from a recent preprint paper by Forbes and colleagues. So it's only come out quite recently, and it's presumably under review at the moment. So it's on a preprint server. And when we consider DSM symptoms, what we can see is that a whole range of symptoms are covered by occur in a very large number of DSM diagnoses. So if we take insomnia, which we're talking about today, we find insomnia as a symptom in 22 DSM-5 diagnoses. We find hypersomnia or sleepiness in 17 diagnoses, and we find fatigue, which is related to insomnia, in 12 diagnoses. Then we find that these are in orange a criteria for major depression. And we find again that these criteria don't just occur in major depression, they occur in a large number of other diagnoses. And the green criteria relate to anxiety, and they also occur in a number of other diagnoses. And restlessness is also a symptom of poor sleep. So we have a huge range of overlapping problems. So what are the daytime effects of insomnia? It's just a list taken from a recent paper, rather than you'll find individual papers, however, on each of these areas. So people who are tired, who have insomnia or have a sleep problem, and I'm using insomnia to some extent in relation to sleep problems in general, people with poor sleep are often fatigued during the day. They may have interpersonal problems. They may be overactive, impulsive or aggressive, and particularly children may show hyperactivity when they have difficult sleep. That in particular may be related to when children have sleep apnea. They may be over-aroused, they'll have attention problems and have difficulty focusing and concentrating. There'll be mood changes associated with insomnia, a reduction in motivation, an increase in accidents or making errors in what you're doing, and reduced motion and regulation. So our little figures here are illustrating some of these things. So if you think about when you've had a bad night's sleep, how you feel the next day, and you might identify with some of these factors. And of course, some of these factors are also criteria for mental health disorders. So poor emotion regulation, maybe being aggressive, mood changes, reduced motivation might relate to depression. We can see things here that relate to ADHD and so on. So these are things that potentially underlie mental health problems. research linking insomnia to anxiety and depression has been in the literature for quite some time. So this was a review that was conducted in 2013, and they drew a number of models that seemed to look at the relationships that people had found between insomnia, anxiety and depression. And most of the studies were reciprocal models of insomnia and being reciprocally related to anxiety and depression. This is a more recent model trying to model the relationship between sleep and anxiety. In particular, it was published in 2020, and trying to look at underlying causes. So they hypothesised, based on the literature, that poor sleep can relate to impaired executive function and cortisol dysregulation, and this is reciprocal. There are cortisol changes. There have been both positive and increases and decreases depending on the study and what we're looking at in cortisol levels in relation to poor sleep. When cortisol dysregulation is also related to anxiety, and anxiety can also feed back onto impaired executive function. So we have this, must have been timed. We have this relationship between poor sleep and anxiety, which is potentially, these are two of the factors that are maintaining this relationship. So overall, what is the evidence that poor sleep or insomnia or poor sleep quality, people measure in these studies, measure sleep in a number of ways. They use an insomnia measure. They might measure how long it takes people to get to sleep, their night waking, their sleep efficiency, or their overall reported sleep quality. But if we just use, again, that shorthand term of insomnia, it's significantly associated with a range of mental health conditions. So general measures of mental health, anxiety, depression, post-traumatic stress disorder, psychosis, rumination, stress, high levels of stress, alcohol abuse and suicidal ideation. Poor sleep predicts later anxiety in children, and there's a reciprocal relationship between sleep and anxiety in children. So this is a study that we did some years ago using the RAIN database in Perth, which has over 2,000 children in it. We used the CBCL for our measures of anxiety and sleep, and our measure of autistic traits. We had autistic traits in both models, and we also had a range of demographic factors. And we looked at the ability to predict sleep from 2 to 8 years. And we looked at the ability to predict anxiety from 2 to 8 years. And this model explained 21% of the variance. And you can see that anxiety at 8 years and sleep at 2 years were uniquely explaining sleep, the children's sleep at 8 years. For anxiety, we're seeing that sleep explains most at 8 years, explains most of the anxiety at 8 years, but also anxiety at 2 years explains anxiety at 8 years, and autistic traits at 2 years predict anxiety. Now, this is interesting because we saw that relationship in adults. I seem to have got my slides on timing. Sorry about that. We saw in autistic adults that autistic traits were also related to anxiety. So that's looking at longitudinal prediction of sleep, and we're finding sleep at both times, but contemporaneous, in this particular study, contemporaneous anxiety and sleep are seem to be reciprocally related. Now, this study is a meta-analysis looking at sleep and mental health. They looked at a range of interventions. They were primarily CBTI interventions. Nearly half of them had an active control group, and most of them had follow-up, with an average being 12 weeks. And looking at them, most of the studies were looking at composite mental health, depression and anxiety. They did also have a few studies on psychosis. I'm trying to remember which other ones they had. I can't remember off the top of my head. But composite mental health and depression and anxiety, sleep when people used a sleep intervention in these, they got a significant effect. They concluded that improving sleep improves mental health, irrespective of the severity of the mental health problem or comorbid conditions that the person may have. So to look more specifically at some interventions, I think from memory, this is an Australian study with 120 clients, 75% female, and mean age of 47 years. And these clients all have anxiety and insomnia. They're randomised to a CBT intervention for anxiety or a CBT intervention for insomnia, and it's internet delivered. And the primary outcome measures were the Insomnia Severity Index or the GAD-7. And I'm just looking here at completers. CBTI was more likely, those who had CBTI were more likely to be in remission from insomnia, 51% versus 27%. They're equally likely to be in anxiety remission, 42 versus 45%. At 3 months follow-up, those who had CBTI were equally likely, this difference wasn't significant, to be insomnia remission, and equally likely to be in anxiety remission. So the first figure is the CBTI figure, and the second figure is the CBT anxiety. And group satisfaction was good for both interventions. So if we have a look at their data, you can see that there's a drop in anxiety and sleep and anxiety in the CBTI group. But you can see in the CBTA group, whilst the impact on anxiety is pretty much the same as in the CBTI group, the impact on poor sleep isn't as good. And they felt that overall, CBTI was more effective for insomnia than CBTA, and that the two treatments were equally effective for anxiety. And they actually recommended that people who had comorbid anxiety and sleep and insomnia were probably better off having a CBTI intervention. We've been working on acceptance and commitment therapy for insomnia in autistic adults, and this is our pilot study, which has recently finally been published for 8 autistic adults, a large age range. Our main outcome measure was the Insomnia Severity Index. So at entry, they all had at least had some insomnia symptoms, and most of them had quite high symptoms of insomnia. We also had measures of mental health, and one of them was the HADS-A for anxiety, and 6 of our participants, 8 participants, had clinical levels of anxiety when they entered the study on the HADS. We got a significant improvement across our group in the ISI at post-intervention and 2 months follow-up relative to pre-intervention, with clinically significant improvement in 5 out of the 8 people for the ISI, and only 6 people did the follow-up. So 4 out of the 6 people at follow-up. But we also found a significant improvement pre to post in anxiety, and 4 of our 8 people, so remember 6 had clinical anxiety, had clinical improvement in anxiety at post-intervention, and 3 had clinically significant improvement at a 2-month follow-up. And you can see there that our people, our autistic adults, liked this intervention, and we're moving on with this work, particularly Lauren Lawson and Eric Morris, looking at this intervention for non-autistic adults as well. What about depression? Here's a study that looked at 1,385 people with insomnia. They didn't necessarily have depression. They were but they measured their depression symptoms. They did an internet CBTI called Sleepio, or they had online sleep education, which consisted of weekly emails. 358 people did the CBTI and 300 did the sleep education. They looked at ISI again as their insomnia outcome, and their depression outcome measure was something called the KIDS. The results showed that insomnia intervention improved depression symptoms in their sample, with the best effect being those for more severe depression symptoms. The reduction of depression symptoms was associated with the reduction in insomnia symptoms, and income. A whole range of demographic factors didn't moderate the intervention outcomes, but they did affect uptake. So things like lower education, lower income, for example, impacted on intake. The one problem with this study is they actually didn't have a follow-up. This is part of apparently an ongoing, some ongoing research. But as you can see here, while both treatments reduced insomnia and depressive symptoms, the CBTI made a much greater impact than just plain sleep education. This is a more recent study looking at insomnia treatment in clients who actually had depression. So all participants had depression and insomnia. And whilst it was only required that they have had insomnia for at least 3 months, many of them had chronic long-term insomnia. So they were being treated for depression, most of them on psychotropic medication. So there were 2 groups, the CBTI group with treatment as usual and a treatment as usual group. Again, a wide age range, 70% female. The Hamilton Depression Inventory score was greater than 17 for entry as well. And the outcome measures were insomnia, depression, dysfunctional beliefs about sleep, which I'm not going to look at today, and quality of life. They also had objective sleep measures, which they looked at as outcome measures and to determine insomnia. And they found significant changes following CBTI. This was a 6-session intervention. And unlike the other ones, which are internet interventions, this was in the clinic. And if we look at what they reported, they found that CBTI in patients here on the ICI, CBTI was better than treatment as usual at 6-week follow-ups. They had baseline measures and a 6-week follow-up measure. There was a greater reduction in insomnia symptoms. There was a greater reduction in symptoms of depression on the Hamilton. And there was a greater increase in quality of life on the WHO-5. So overall, CBTI in patients with chronic insomnia and major depression resulted in a significant improvement in the intervention group for sleep efficiency, which was one of their objective measures of sleep. Now, sleep efficiency is the amount of time that you spend in bed actually asleep as a percentage, and a sleep efficiency of 85% or more is considered good. So in this group, the average sleep efficiency prior was 82%, and after CBTI, it was 86%. So sleep efficiency, severity of insomnia, quality of life, and symptom score on symptom scores for depression. So to conclude, mental health conditions don't fall into neat categories, and that's probably no news to those of you who are listening now or watching later. Mental health conditions are more often than not comorbid. Symptoms or conditions that cross mental health categories, therefore, may be targets for intervention. We may do a better job of helping our clients if we target something like insomnia, or as we saw earlier on, and tolerance of uncertainty might be another target in certain conditions. And so insomnia covers a range of mental health conditions, and it may be that this is something where we have clients with comorbid insomnia and mental health diagnoses, that insomnia may be a better target, or at least a co-target for intervention. Certainly, there's mounting evidence that treating insomnia leads to improvements in general mental health and in anxiety and depression. And so investigating transdiagnostic factors in mental health also may lead to a better understanding of the causality of mental health problems in the general population. So what might be the implications for clinical intervention? From a theoretical perspective, we may be better off considering mental health from a dimensional perspective, and the signs and symptoms that we're having a look at may be the endpoints. So we have a sort of dimensional hierarchy with overarching factors at the top, going down to perhaps biological factors, behavioural things that we see happening for people, right down to particular signs and symptoms that our clients are telling us about. Symptoms we know can interact with each other. For example, we saw that insomnia was associated or related to a number of, or caused a number of symptoms that are also related to poor mental health. And if you've got insomnia and you've got a mental health condition, they can feed back on each other. So all of these insomnia and associated symptoms may form networks. RDoC and biopsychosocial models are one way to understand transdiagnostic factors in mental health processes. But we also have to work out what are proximal and distal causes of poor mental health. So we might want to consider, in terms of intervention, it may be the things that are happening in the here and now that we might want to work on, or it might be that there are distal causes back in childhood. We might want to try and help people reappraise how they think of those more distal factors. And so, what I've done here is just, this is a very crude, simplified hypothetical dimensions. So we start off with this, maybe something like arousal, the arousal systems in the body. They can lead to somatic, and we might see someone reporting somatic and sensory symptoms that relate to some sort of dysfunction, biological dysfunction in the arousal system. Maybe one day we'll have a drug that's going to work on that, for example, but at the moment we're seeing somatic and sensory symptoms. And as a result, we might be seeing poor sleep quality and anxiety and disturbed mood. And these are all interrelated. And so we might want to think about, well, can we do something about how people think about these symptoms? Can we intervene for sleep? And so on. So building these kinds of hierarchies hopefully will give us ways to think about what's going on in our clients from an intervention perspective, but also think about the kinds of research that we can do to understand what factors underlie mental health problems. From a practical perspective, clients with 2 or more comorbid conditions are the rule, not the exception in general. So we need to move away perhaps from a focus, interventions that focus on single conditions, and think about how they might be affecting multiple conditions. We need to tease out common factors across comorbidities. And Dalgleish, for example, in his and colleagues in their 2020 paper, suggested that one answer to this was to develop modular interventions that targeted various aspects of mental health issues that people might present with, and that we then looked at individual clients and put together our own package based on the modules that were available to us. More recently, Roos is moving to the idea of personalised medicine, which may be a bit difficult for us at the present time. But these interventions are targeted completely to the individual client. And they look at ecological momentary assessment using smartphones, so digital phenotyping, where people are prompted to answer questions about perhaps how they're feeling, about their mood, about how tired they are, and so on, at different times of the day. And that enables us to build a network of interrelationships. And I've just got a sort of hypothetical network there of the symptoms that the person is reporting, And the red lines in these networks are negative relationships, and blue lines are positive relationships. And the thickness of line indicates the strength of the relationship. And so if we look at that central yellow circle, that might be a target. That particular symptom might be a target for our intervention, or perhaps it's the relationship between the green and the blue, or the two yellow ones, which are the stronger relationships. So this is a new way that people are thinking about potentially addressing clinical intervention. Now that sounds difficult, but which the authors admit, that they suggest that one way that we could could be done in the future is clients typically are on a waiting list before they get to see you. So you have the client doing their digital phenotyping with their smartphone while they're on their waiting list. So they come to you and you already have the data, and you've been able to think about what might be going on for them before they first come in to see you. So thank you very much for your attention today.